Hi, this is M. Prasad Nair. Today we are discuss about the liver function tests. So liver function test, liver is the largest organ in our body weighting of about 1.5 kg, that means 1.5 kg. Liver is also called kitchen of our body. Carbohydrate metabolism in feed state glycogen synthesis and excess of glucose is converted to fatty acids and then triacylglycerols, which gets incorporated to VLDL and transported to the adipose tissues. In fasting state, glucose concentration is maintained by the glycogenolysis and gluconeogenesis, and protein metabolism, synthesis of albumin and various plasma proteins expect the immunoglobulins. So most of the coagulation factors like fibrinogen, like 2, 5, 8, 7, 9, 10 and 11, 12, 13, these are the things. So out of this 2, 7, 9, 10 cannot synthesize without the vitamin K. Transportation of proteins, transport proteins like transfer in amino acid metabolisms and urea formations. So lipid metabolism, synthesis of lipoprotein, phospholipids and cholesterol. Fatty acid metabolism, beta oxidation, ketone bodies and formations, and also bile synthesis. So excretions and detoxification, conjugations of and excretion of bilirubin. Cholesterol is excreted in the bile as bile acids and cholesterol. Steroid hormones are metabolized and inactivated by the conjugation with gluconic acid and sulfate and are excreted in the urine. So drugs are metabolized and activated by the cytochrome P450 of the endoplasmic reticulum and excreted through bile and urine. So miscellaneous functions: iron storage, vitamin A, D, E storage, B12 storage. So liver has very large functional reserve. Deficiency of synthetic functions can only be detached if liver disease is very extensive. So total bilirubin is 0.2 to 0.8 milligrams per day. Conjugate bilirubin 0 to 0.2 milligrams per deciliter. Total protein 6 to 8 grams per deciliter. And also albumin is 3.5 to 5.5 grams per day, and coagulation factors prothrombin like 11 to 12 seconds. So enzymes are like ALT, like alanine transferase and aspartate transferase, alkaline phosphatase and gamma glutamyl transferase, 5' nucleotides. So what are the special tests? So bile acids levels and blood ammonia, alpha 1 antitrypsin, alpha 1 phytoproteins and hepatitis markers, immunoglobulins and ceruloplasmin ferritin. These are the liver functions, like liver function test, serum bilirubin. So this whenever hemoglobin. So after hemoglobin, human what the happening means him. So 120 days will be after 120 days of lifespan of RBC. So him is conversions of bilirubin. So he biliverdin to bilirubin. So in bilirubin, so it is converted to the bilirubin to excreted through feces, that is stercobilin. Excreted by urine is urobilinogen, and globin is reutilized. So bilirubin is also here albumin combined with the uptake of oxidation. So this defects, conjugated defect, and these are the different conjugated like disorders like neonatal jaundice, toxic jaundice, and Crigler-Najjar syndrome and Gilbert disease. These are uptake of defect of in plasma, and so bilirubin diglucuronide. So bilirubin diglucuronide has bacterial enzymes and urobilinogen feces excreted 300 milligrams per deciliter. This is the condition in intestinal system. Total serum bilirubin 0 to 0.8, conjugated bilirubin less than 0.2 milligrams per deciliter, unconjugated bilirubin 0.2 to 0.6 milligrams per deciliter. Vandenberg reactions. Normal serum gives an negative Vandenberg reactions. Principles of the reactions: the reagent is a mixture of equal volumes of sulfonic acid in dilute HCl and sodium nitrate. So that diagenate sulfonic acid above the mixture reacts with the bilirubin to form the purple colorized azobilirubin. Direct positive conjugated bilirubin gives a purple color immediately on the addition of the reagent. Indirect positive and purple color is developed only when the reagent is methanol are added. So unconjugated bilirubin gives color only the methanol is added. So biphasic purple color develop on addition of reagents, and additional methanol intensifies color and elevations of the both conjugated and unconjugated bilirubin. Indirect positive is like hemolytic, and direct positive where that means obstructive jaundice. Biphasic also both hepatic. Bilirubin in urine, normally bilirubin is absent in urine. Conjugated bilirubin, being the water soluble, is excreted in the urine obstructive jaundice. This can be detected in the Faucher's test. Urine urobilinogen in normally trace amounts in present. So in obstructive jaundice, no more urobilinogen is present in urine. Because of bilirubin cannot enter into the intestine. Note the presence of bilirubin in urine and absence of urobilinogen in urine is seen obstructive jaundice. In hemolytic jaundice, increased productions of bilirubin causes increased the formations of urobilinogen which appears in urine. Increased urobilinogen in urine and absence of bilirubin in urine is seen in the hemolytic jaundice. So fecal urobilinogen normally about the 300 milligrams. So increased in hemolytic jaundice in which color of feces is dark. In obstructive jaundice, urobilinogen is not excreted through the feces and the color is the feces is pale. Jaundice clinically jaundice appears when bilirubin concentration is more than 3 milligrams per deciliter. So level between the 1 and 3 milligrams per deciliter is subclinical jaundice. Classifications of jaundice: prehepatic and hemolytic and unconjugated by hyperbilirubinemia. Causes increased productions of unconjugated bilirubin from the hemolysis, sickle cell anemia, rapid turnover of RBC and neonate, and physiological dangers. Bilirubin is 5 milligrams per deciliter, and corn ectors bilirubin more than 20 milligrams per deciliter, and brain damage due to the entry of bilirubin and no blood-brain barriers. Decreased uptake of bilirubin by the hepatocyte, that's called Gilbert syndrome. Decreased conjugations of neonatal jaundice and drug inhibition, and Crigler-Najjar syndrome, hepatocellular dysfunctions. Obstructive jaundice, post-hepatic jaundice, and conjugated hyperbilirubinemia, decreased secretions of conjugated bilirubin into the canaliculi, hepatocellular disease and hepatitis, and decreased drainage, intrahepatic obstructions of by drugs, cirrhosis, and extrahepatic obstructions, stones, carcinomas. Hepatic cellular jaundice, acute hepatic is usually caused by the viral infection. Hepatitis A, C, D, E by toxins, paracetamol and carbohydrates. These are how these things, biochemicals and laboratory findings. So serum albumin 10 to 12 grams per deciliter albumin synthesized in the liver daily. It is estimated very valuable and in excess of chronic liver disease, and low serum albumin in levels is commonly observed in the severe disease, and prothrombin time is 11 to 12 seconds, and prothrombin time is prolonged in severe parenchymal liver disease due to the decrease of synthesis of prothrombin, and vitamin K is required synthesis of prothrombin. Vitamin K deficiency can also lead to the prolonged prothrombin. If prothrombin time returns to the normal after vitamin K injection, it is indicates that hepatocytes infection is good. Transaminase, alanine transaminase, asparatate transaminase, serum glutamate pyruvate transaminase, serum glutamate oxalate pyruvate transaminase. Alanine transaminase is primarily localized to the liver. It is the marker of enzyme of the liver. So alanine transaminase is present in cytosol hepatocytes, and asparatate transaminase is present in the wide variant tissues like heart, liver, skeletal muscle, kidney, and brain. So asparatate transaminase is both in the cytosol and the mitochondrium of the hepatocytes. Liver contains both enzymes but more in ALT. Estimates the very useful for the assessing of the severity of the prognosis of liver parenchymal disease, especially infectious disease. So also very useful as a screening test in the outbreak of infectious hepatitis. So elevated of alanine transaminase and asparatate transaminase highly elevated more than 20 times. Viral hepatitis, drug or toxin induced hepatitis necrosis moderately elevated 3 to 20 times. Chronic hepatitis, alcoholic hepatitis, acute autoimmune hepatitis, and acute biliary tract obstructions. Alkaline phosphatase 3 to 13 kilohertz. So a family zinc metallo enzymes with serine at the active center. So they release inorganic phosphate from the various organic phosphates. In the liver, it is found in microvilli of bile, canaliculi, and one of the sinusoidal surface of the hepatocytes. Other important source of alkaline phosphatase is bone. So alkaline phosphate is highly elevated in the obstructive jaundice and bone disease and like trackets. So gamma glutamyl transpeptidase normal levels at 10 to 15 international units per liter. So it is the membrane bound glycoproteins which catalyze the transfer of gamma glutamyl group to the other peptides and amino acids. Very useful in the diagnosis of obstructive jaundice and not elevated in the bone disease. So it is microsomal enzyme. So serum gamma glutamyl transferase is highly elevated in the obstructive jaundice and alcoholic liver disease. The enzyme is an inducible enzyme. So 5' nucleotide is normal 2 to 15 internal